Welcome. I'm Fung, and you are watching Just Picture It. Tonight, we'll be looking at new ways to keep people healthy. What can we do within a community to look after ourselves and improve our health? It turns out the answer is a lot, but we need the information in order to make the decisions, understand what's going on, so that we can get us healthy. Now, the United States is full of people helping each other do better. So somewhere, someone has worked out some of the answers. Tonight, we're turning our focus on San Diego. Dr. James Killeen is professor of emergency medicine at the University of San Diego, and he's been working there to meet the needs of the community. Tonight's guests, Desmond and Kevin Montgomery, are here to show us what's been happening. Desmond is the president of the CIMI Group, a leading innovator in healthcare and public health solutions. His forte is connecting government, non-government, and private sector leaders with community stakeholders to solve problems. Kevin Montgomery is an innovator, academic, and researcher who has been doing work with the Army and the U.S. Department of Defense, amongst many other important players. He is the CEO of a startup company called IntelliSense Technologies. It spun out from Stanford University and NASA, and it provides massive data integration at a global scale. This means it's collecting millions of layers of data from sensors, online databases, social media like Twitter, Facebook, and thousands of blogs, as well as satellite and aerial imagery. Kevin is also the 2013 recipient of the Entrepreneur of the Year Award. Welcome, Dan and Kevin. So how did you guys get started working with San Diego?
Well, I think it's best to start with the doctor at the emergency department. Okay. And so here we have an image of a doctor, in this case, a famous doctor from the TV show ER. But when Dr. Killeen started this within other emergency department doctors, they realized that they were providing the most expensive care as the patients come in to do this. And what they wanted to do was create a picture in their minds of what the patient was going to look like before they actually came in. The more they know, the more intuitive they are about the patient, the more effective and timely the care will be. So as they started forming their picture and their storyboard in their head, they started with a wreck. You know, a patient they're in a wreck, they call the 911 dispatch.
This is at the police.
At the police. So now we're at the police department.
Yeah.
Then it goes to the first responders at the fire department. So there's little bits of information being collected. So as they're drawing the picture in the head over at the emergency department, the doctor, they're moving across the system. More data is being collected. They gather at the emergency department, and they're still filtering the information that comes in. So as they did this, they realized that there are a large number of stakeholders that all had a common thread. They needed to create a picture in their mind and be able to move forward and to have a common way of talking. So when they talked to the fire department, when they talked to the police department, they weren't using the same picture in their head to move forward.
Okay, so you've got a lot of people here.
A lot of people.
And they're all talking their own different languages, the language of the police, the language of the firefighters, the language of the ambulance drivers, the emergency room people, the doctors, the nurses. They're all talking differently. So Dan, how did you engage them? What happened? How did you get started?
Well, it's really a two-step process that we had for this. The first one was to get all of the stakeholders to agree to meet in the room together. So, once again, going through the process like we did before, you have someone calling 911, it goes to the dispatch system, and they have this drawing, and it's a pretty comprehensive drawing that takes you through the entire paradigm or the entire timeline from the ambulance coming in. They start doing assessments and triaging with the nurses. They gather information. They're pushing information out to other systems. But if you notice these lines, they're not connected. There's not a cohesive whole of this. So as they go through the process, they finally get down to the emergency department. As the emergency department moves forward, then it finally goes to the doctor. The doctor is still, though, dealing with paper reports and paper information that somehow get in, or they've got to recreate it and re-triage the patients.
Okay, so now let's make this real. I worked with some people in the Navy, and they said that the Navy is the largest employer in San Diego. And in addition, I understand San Diego's climate is very, very good. And there are a lot of vets that have moved to San Diego, and some of them are homeless. So how does this whole system help the situation for a homeless vet in San Diego?
Well, so as we look at this and this process, the idea is to get the right stakeholders at the table. And so as you mentioned, it wasn't just the hospitals and the first responders and the fire department. We still needed to include other people, such as the Veterans Administration and others. So here we have a full picture. And as we see the comprehensive picture, we're able to get all the stakeholders together at the table to move forward and to be able to build a common picture. So the first step is imagine hospitals, public health, EMS down here, over there, and now you have medical clinics, the VA as you had talked about. And as we move forward with this, imagine all these people together at a whiteboard, drawing pictures. And as they're drawing pictures with their pens, they're discussing, what do you mean by this information? What do you mean by this piece of information? Fortunately, whiteboards allow for a lot of erasing. But over a period of time, what they were able to do was to build a common path and a common road that goes up through this process to be able to move forward together as a community where each individual, like Dr. Colleen, was able to look at the information and say, wait, they all had their aha moment. And I think that was a big piece of the process with this, as they were able to move forward and to be able to bring people together at the table to have a common view to protect that patient. So as we go forward with the patient, now you're looking, as you mentioned, there's a lot of veterans there. A lot of the people that had the need that would go to the emergency departments all the times were veterans that needed help and information to do this. But the process really starts with the ambulance.
Okay, so let's take a look at this ambulance situation. Now, I understand that the homeless vets end up being brought for multiple trips. I think you said frequent flyers.
Yes,
frequent flyers on the ambulances. And what people are trying to do by coordinating and talking is to reduce the number of trips that the same homeless vet would take on an ambulance.
Right, so there's two aspects to this. One, obviously, is for the care of the patient. So they found that different hospitals were treating the same patient, and they were all going through the same picture process, collecting the information and gathering a picture. So as you see from this slide, what we're able to do is you have multiple ambulances going into different systems, but they have this new thing in the middle here called an EMS hub, Emergency Medical Systems Hub. They found a common point where they could start building a common picture for the information that comes out. So the fire department, the hospitals, the law enforcement, and the Veterans Administration, the clinics, were able to build these systems and be able to have a more common picture.
That's still a lot of paper. That might be a common picture at that funny little EMS hub thing, but it's still a lot of paper. Let's take a look at what kind of paper.
Well, so let's look a little bit at the paper. So here's then the EMS hub, and there's a lot of information here. These are patients that are coming in. They're en route, in this case, to the University of California, San Diego, but they could actually tell you where their locations, where they're going to other hospitals. Just this simple piece of paper here, a lot of information to digest. What they found is there's too much information to digest because there's a lot of hospitals, there's a lot of patients. But they did find one thing, and they did find that the same patient, the same information, we could get the same vitals and the same information, but also if we could reduce it to pictures. So here you have images, notes about the patient. Who are they? Were they there before? Was this a person in the emergency department before? And finally it shows up as an EKG.
Okay.
So,
let's go back to the previous picture.
Yes.
So what you did was you took all of that text in the first picture and you reduced it into a number of boxes that people could, if they wanted to look at a particular box, they could go straight to that box.
Correct.
And then you also added pictures so that people could get used to the idea that, okay, if I need to look at the EKG, I press this button.
Right.
Okay. Let's go to the EKG.
So when we look at the EKG, which is what they're looking for a cardio patient, as they did this, they found that we have all these patients going around, and we found that we're getting the EKG. But wait, I saw this EKG last week. I saw this person last week. This is a real true problem that we have because I have this, as you said, frequent flyers. We have them, but these are the people in the most need. They're the veterans. Many of them are homeless. Most of them have PTSD. So they really need the care, and it's also expensive to provide them care, have them show up in the ambulance.
Okay, so let's take a look at this next picture, which is, I love it. The whole idea is that in the emergency room, you've got people talking EKGs, MRIs, all these acronyms. Meanwhile, the police are talking about all of their separate pieces. So how do we do it so that they can have a common language? And it looks like all of these people know how to read maps.
Well, and this is really where it came to life. Okay. So the visualizations that they had on their whiteboard and the dreams they have came to life with this simple. This is static, but it helped them actually see, wait, the same patient showed up to multiple locations. Wait, this is the same patient we had last week. What can we do to help this patient so they don't come to the emergency room? How can we avoid them coming in again? But this also started building a larger view where they're able to bring in new stakeholders. So the Navy got directly engaged with theirs, with the leaves. They started talking to cruise ships that are coming into this. But other populations, community clinics, homeless clinics, and those all of a sudden started saying there's something for us all to be gained by joining into this process.
So let's talk about mapping. So Kevin, you've been doing lots and lots of mapping with IntelliSense. Tell us about how the common language of maps, how have you found the common language of maps help people to work together?
Well, I think that is a common universal way that everybody can communicate. Everybody understands a map, but they can view it from their own perspective. You could be looking at a map from your role or whatever, let's say as an emergency room physician, and looking at where's my patient, what's going on with them. But I could be somebody that's a first responder looking at, well, where's the fire, what are the routes that I can go through, and looking at the same data but drawing very different conclusions from it.
Okay, so you've got different people doing their own thing, but they're seeing how their particular activities connect together because they're working on the same person at the same place.
Absolutely, and it's a framework for collaboration, really, is what we found, is bringing in all this multimodal data from many, many different sources. You can do all kinds of different things with it, but what you need to do also, besides ingesting that information, is you need to make better decisions. And one thing that we need to do in order to do that is to collaborate with others and come up with a shared, unified vision of what's happening and coordinate our actions together.
Okay, so all of these different people are using these different instruments. In IntelliSense, you sense different things, right?
Absolutely.
Okay, and so tell us about what we're looking at here.
Okay, so I brought a few different little medical devices that were pretty handy. So we have blood pressure cuffs and pulse oximeters and things like that. And in the back of an ambulance, there's all kinds of different medical devices. Also on a life flight, when we're transporting somebody by helicopter, same sort of situation. Lots of different medical devices plugged into the patient. Going back to what Dan was saying, it would be really useful for the physician to know what is the condition of the patient that's coming into their emergency room soon.
Yes.
How do I know what resources I have ready to handle them? So what would be really handy is being able to have all of these devices then be able to transmit their data, maybe through something, let's call it a medical data router, that could talk to all of these devices, let's say in the back of the ambulance or back of the aircraft, and then transmit that data down to the ground so that the physician knows who's about to show up in their emergency room.
Okay, so I don't think our audience might understand what a router is. So let's you've got lots of devices. Different people are reading different things. And what you're saying is collect all of that information, put it together in a single place, and then send it out again to the people who need to know that specific information.
Yeah, maybe one good way to look at it is right now the condition of the patient is known in detail by the caregiver that's in the back of the ambulance with them, but not by the physician that's going to see them in 2 minutes when that ambulance arrives.
Yep.
So instead, wouldn't it be great if we had some sort of device, let's say an electronic instrument, that would talk to all of these and then be able to transmit that data somewhere else?
Okay, so I have a device here, and it says IntelliSense on it.
So one of the things that we came up with at IntelliSense and that we spun out of our lab at Stanford is we saw all kinds of sensors out there in the world, and we had this idea, what if we made one box that let you plug any kind of sensor into it and transmit that data from anywhere in the world? Makes sense. Well, it turns out these medical devices are just sensors too. They're sensors for the human body. So we could take this device, put it in the back of an ambulance or aircraft, and it could pick up the wireless or wired data from all of these medical devices and then transmit it to the ground where you could have a doctor watching that data live.
Okay, I'm starting to have an aha moment here. Kevin, you came from NASA. So at NASA, you've had to work out how to transmit information over long distances, collect things from all kinds of different devices, and you've come up with things from that background, and now you're taking that and applying it in the field of health, where people have said, oh, my way or the highway on this data, my way or the highway, and they don't want to talk. But what you're saying is that you can take your Martian experience and bring all of these different devices together, and you can use tools that you came to know about through experience and pull them together in a box like this, which somehow jumps the hurdle, which today everybody's talking about electronic health records, and they're saying, well, the VA can't talk to the community health centers because they've got different health records. Are you saying this thing could help?
Absolutely. So it can take data from all those different devices that exist there now. But one of the things that going back to what you mentioned about NASA and also working with the DoD sometimes, is their needs are really unique for their fields and their areas. But actually, then they're more than happy to have all that technology transition. So good example. In the back of an ambulance, we may have all kinds of different vital signs devices, but working with NASA, we developed a device that lets us take a bunch of those together and build it together into one. And I actually brought one with me. This is a device called LifeGuard that we built with NASA a number of years ago out of my lab at Stanford that basically replaces one of those big vital signs monitors that you see in pretty much in any back of an ambulance and makes it much smaller. It makes it able to transmit its data. So we can shrink those things down because NASA needs things to be very lightweight and very small to go into space, but then we can turn around and use this on the ground too.
Yeah.
Now, one other thing that we haven't talked about, though, that's really important is it's one thing to take all this data and transmit it, but we can't have a bunch of doctors watching a bunch of screens of raw data. That just isn't a good way for them to spend their time. They need to be spending their time touching patients. So we've been working lately with the Air Force to take that raw data and build a new version of the LifeGuard device that then also can do real-time analytics on that data. What does that mean?
What does real-time analytics mean, Kevin? And what does it mean to a homeless vet who has been picked up by an ambulance?
What it means is that rather than the caregiver in the back of the ambulance looking at a bunch of raw data or transmitting a bunch of raw data to the hospital where we don't have enough physicians to sit and watch all those screens, instead this device has built into it smarts to look at this data and tell it higher level things like patients low on blood, low blood volume, cardiac arrest. And what's really neat about it is it's using some really advanced algorithms and things that are just coming out from academia where we can actually predict whether the patient is going to go into distress or whether that patient's going to crash before it happens. So the caregiver in the back of that ambulance can know, I need to pay attention to this person right now. And that directly came out of our work with the military where you have one medic taking care of a bunch of guys at once. Same thing can happen in the back of an ambulance and then transmit that higher level information back to the hospital.
So what you're telling me is that in San Diego, some breakthrough things are happening that are allowing different groups of people, the police, the firefighters, even the social service workers. So I heard from Dan, in fact, earlier that through the use of these sensors, devices, these analytical tools that can predict what's going to happen, that in fact emergency room admissions have decreased by 70%.
Exactly, that's what I understand as well. And one aspect that I think is really important is What we're talking about here is just for one single patient. But now let's start to think about what happens in a community. At any one time, we could have tens of patients, hundreds of patients in transit. How do we know which is the right medical facility to send them to based on their condition, based on medical resources? And this becomes so much more important when we're dealing with a disaster scenario. One of the problems that happened at the Oklahoma City bombing is there was such a mass casualty event that patients were, to oversimplify, scooped up and taken to the nearest facility that may have been overextended in that one area of specialty that they required.
Yeah.
So by integrating this information from all of these patients together with live feeds of the medical resources that we're getting from Dan and from others, we can then match up the needs of the patients that are inbound with the abilities and resources of the medical facilities and optimize all of that.
So, guys, how do we take this further? San Diego is proving that this stuff is working. Is this correct? We are showing that it is possible to collect data and share it amongst different stakeholders. Even that is a surprise to many people. So now we've shown that. Why are we keeping it a secret in San Diego?
Well, I think you need to start small, learn from that, and then grow big, as opposed to trying to do some massive thing from the outset. You learn so much when you do things from the ground up and then build off of a success. It's a lot easier to attract people to it as well.
You're the technical guy. He's the guy whose forte is bringing government, non-government people together. So what do you do?
Well,
what are your plans, Dan?
Well, let's talk about the vision. This actually started a long time ago in San Diego. And over the last 3 or 4 years, they've gotten the San Diego region, the community, they're there. And it was funded by the federal government. It's called a beacon. And it's a beacon for a path forward. So you visualize a path forward in the light. Well, they've seen the light.
Yeah.
So now what's happening is they said we need to extend this beyond. We need to move this across the country. We've learned a lot, but others have too. So how can we better collaborate together? So fortunately, one of the things that Kevin's firm brings in is collaborate.org, which is a common platform so those pictures that were on whiteboards we can actually capture. And we can help them to educate and move people forward. So what's happening now with San Diego is they have set up the Beacon Education, Analytic, and Coordination Hub, otherwise known as the Beach. So they're moving their efforts forward and they're moving out to collaborate with this. So I think you're going to see more of these types of things. And each of those stakeholders, when we went around the picture and we had the fire department, the emergency room, the ambulance and those, as these people moved around the process with these, we now have their peers in other jurisdictions all around the country. We have the private sector saying, wait, that's a pretty good idea. How did you come up with that? So one of the things that's happening now is Dr. Colleen and his chair, Dr. Chan, are moving this out across the country and launching that forward to do this. Through the work that Kevin's done with collaborate.org, it won't just be domestically. We have people coming in from around the world. So it's really an international model to do this.
So we all of us know we're right now in the place where the Affordable Care Act is just rolling out in this huge controversy nationally. Meanwhile, it sounds like there's real progress being made in San Diego. How do we move forward step by step in a reasonable way to help each community almost do what San Diego did? One thing I've heard of is the Institute of Medicine has written a report about the local community as a learning system for health. So it sounds like San Diego is just a terrific example of that. So how can we take this and make this a learning system for health? Can collaborate.org be such a thing?
I think it can certainly facilitate that, but I'm going to definitely let Dan be the one to get to address this.
Yeah, so as we look at this, there's a lot of opportunity at the Affordable Care Act. It's changing the way people think about their health care. It's in the news every day for a number of reasons. But what the focus they did in San Diego is they said, let's start small, the ground up. It's really about the neighborhood and the people in the neighborhood working together. And it's about the individual patient. And we see, as Kevin described, the devices that can help individual patients to improve their health and move things forward. So the Beacon, there were 17 of them originally funded. They're bonding together to move this forward in order to enable people, empower people to be in charge of their own health care. But let me correct that. they're empowering people to be in charge of their own health. So when you talk about the Affordable Care Act and you talk about those, it's the business of healthcare. It's not about health. One way to save money is to have people who are well and aren't sick. So this is part of the process to move forward from the bottom up while the healthcare is coming from the top down, and the two will meet in the middle. And it's going to be a little bit interesting to see as they merge together. But I think the outcome in the end, the technology is now empowering patients to be in charge of their own health. So now let's make them healthy and well, and let's get them out of the emergency department. As Dr. Kleen says, we are the most expensive. We're good healthcare, but we're expensive. So let's transform that and let them work together on their own and with their family and their community.
Well, I think we've heard a voice of hope. This is a very difficult area, the transition from healthcare to healthy, thriving communities. I am encouraged, and I have inspired by the story of San Diego and how they have mapped a road to health with the help of NASA and the Department of Defense and the VA working together, but also with the community health centers, the social services. What I see is a very hopeful story of how the community has come together to help the homeless vets, amongst other people in their community, to live more happy, healthy, thriving lives. So thank you, Dan, for coming.
Thank you for having us.
Thank you, Kevin, very much. This has been a great session. And thank you for bringing your toys. It's been fun. Okay, good night. That's it for us. Just picture it.